Hello, everyone. Thank you so much for joining us today. We are going to get started in just a minute. Good afternoon, everyone. My name is Maya, and I am the program manager of the Behavioral Insights Group. I am delighted to be joined here today by Allison Oakes and Jackie, the BISG co-president. And this is our second series of the program we launched earlier this year called Building Behavioral Design Teams for Public Good. And Allison is joining us from Nudge Unit at Penn Medicine. And now I will tell you a little bit more about the program. And Jackie will then introduce our speaker for today. The Behavioral Insights Group presents Building Behavioral Design Teams for Public Good, a new series of talks with practitioners working in behavioral science units within governments and nonprofits to build and test solutions for social impact. This series will highlight how these units are formed, how they work, and will feature important ongoing projects focused on public good. This series forms part of the ongoing Big Mentoring program, which we launched in August. Through coaching and workshops, the program aims to build the participants' capacity to establish behavioral design teams in their organizations that will leverage system design thinking, behavioral insights, and innovative adaptive leadership frameworks in order to design more effective policies, programs, and services for complex social issues. Now, Jackie, please take it away. Thank you.
Great, thank you. So as Maya mentioned, I'm Jackie Lefkowitz. I'm a second-year Master in Public Policy candidate here at HKS, and I'm also the co-president of the Behavioral Insights Student Group. So it's my pleasure to introduce Allison Oakes. Allison is an advanced fellow in health services research at the Center for Health Equity Research and Promotion at the Crescens VA Medical Center and the Penn Medicine Nudge Unit. She uses a multidisciplinary approach to examine how varying financial, behavioral, and organizational factors influence patterns of care utilization and the delivery of evidence-based and preference-sensitive care. Her research interests center around the measurement and improvement of healthcare quality and value, with an emphasis on the identification and elimination of low-value care. Her current research leverages insights from behavioral economics to design, implement, and test approaches to improve clinician and patient decision-making. Allison also holds a PhD in health services research and policy from the Johns Hopkins Bloomberg School of Public Health. Allison, we're so excited to have you today. A quick message to our audience: please send us questions through the Q&A box, and we should have some time at the end to take a few of your questions. And with that, I'm going to pass the mic to Allison. Welcome.
Great, thanks. Hi, everyone. Thanks, Maya. Thanks, Jackie, for the introduction and invitation. I'm incredibly excited to have the opportunity to talk with this group about the Penn Medicine Nudge Unit and to share our experiences on behalf of our director, Dr. Mitesh Patel, as well as the rest of the team. So today we're going to be talking about nudging healthcare for good. First, just a quick agenda. We'll do a little bit of background and a bit of a healthcare primer. We'll then talk about the Penn Medicine Nudge Unit specifically, our mission and approach to research and implementation. We'll then talk a little bit about daily operations, what our project intake processes are like, and what our staffing model looks like. We'll then walk through some of our actual projects, discuss lessons from the Nudge Unit, and then finally touch on dissemination. Okay, so diving into things. I realize everyone on the call here may not necessarily be a healthcare or health services researcher, So I wanted to provide a bit of an overarching problem statement that motivates much of this work. And that's that the US overspends and underperforms on healthcare. Our system is also difficult to access and navigate. In 2018, 8.5% of the population, or around 27 million people, were uninsured, and 29% of people were underinsured. In terms of organization of our healthcare system, looking at this figure here, there's a complicated web of interrelationships between government, insurers, medical and special societies, state medical boards, and academic medical centers and hospitals. There's also a multitude of other corporate players and constituents like the biotech, pharma, medical device, and health information technology sectors. And then, of course, caught in this web are some 900,000 practicing physicians, as well as millions of other healthcare workers and the populations that they serve. Turning to this other figure, as a share of GDP, healthcare spending in the United States accounts for 17.7%. We spend almost twice as much as the average OECD country on healthcare, yet we have the lowest life expectancy. And that lands us as a major outlier way over here on the right-hand side of this graph. Contributing to this, the US has the highest chronic disease burden and an obesity rate that is 2 times higher than most other developed nations. Using the term system loosely, our healthcare system is costly, inefficient, ineffective, and oftentimes unequal for many. And this means that there's a lot of work to be done. Setting major health system issues aside, human behavior is the final common pathway for most advances in medicine. No matter how effective a medication, protective a vaccine, or beneficial lifestyle modification, clinicians must recommend them and patients must engage with them in order to achieve improvements in health. That is to say, a clinician has to recognize that a patient meets criteria for a test, therapy, or treatment. They have to offer or prescribe it to patients, and the patient has to accept it and adhere to that regimen in order for it to work. No matter how great a medical breakthrough is, if a doctor does not recommend it or a patient does not accept and use it, it will not translate into any benefit. Unfortunately, evidence suggests that this kind of medical decision-making is often suboptimal. Such issues with medical decision-making lead to problems in healthcare quality. And healthcare quality is defined by AHRQ, or the Agency for Healthcare Research and Quality, as the degree to which health services increase the likelihood of desired health outcomes and are consistent with professional knowledge. Unfortunately, medical decisions do not always follow this guidance. We often do too much or too little when it comes to healthcare. In terms of doing too much, it's been estimated that 42% of Medicare beneficiaries, 15% of Medicaid patients, and 11% of commercially insured patients, or about 50 million people in total, experience one or more overuse events per year. And this amounts to more than $100 billion in wasteful spending each year. In terms of doing too little, along the entire care continuum, we fail to provide effective and affordable medical interventions when indicated. While hard to capture the full effect of underuse on morbidity and mortality, examples include underuse of cancer screenings or effective medications such as statins. So if clinicians and patients are both explicitly interested in health as an outcome, achieving the best health possible, why does this happen? We know that some of these failures are predictable. They're the result of heuristics and biases, and these issues abound in healthcare. In 2018, O'Sullivan and colleagues put together a helpful table of some of our favorite heuristics and biases and directly applied them to healthcare. Here are just 3 examples. So related to a viability bias, which is when more recent and readily available answers and solutions are preferentially favored. In healthcare, we could see how a recent missed pulmonary embolism could prompt excessive CT angiograms later on in low-risk patients. In terms of the framing effect, this is when we react to a particular choice differently, depending on how information is presented to us. We could see how a pharmaceutical company may present drug A as having a 95% cure rate and suggest that this is superior to drug B which has a significant 2.5% failure rate. We interpret these things differently, especially things that are presented as benefits versus potential harms. And lastly, maybe my favorite example from this much larger table that they have in the paper is commission bias, which is a tendency towards action rather than inaction. And this in particular is a bias that I think drives a lot of overuse. So an example of this are historical transfusion targets in GI bleeds. The approach was traditionally to aim for higher targets rather than doing nothing. And this is because of an overwhelming feeling in medicine that it's better to be safe than sorry. So seeing in this action and looking to the figure to the right, this figure is from work within our group and displays the unadjusted rates of clinician ordering and patient completion of colorectal cancer screening over the course of the clinic day. We wouldn't think that time has anything to do with healthcare quality, but here we see that order rates hover around 37% in the morning, but progressively drop over the course of the day, all the way down to 23% at 5 p.m. And interestingly, trends in patient completion rates were similar. We see similar trends over the course of the day in terms of increasing low-value care and decreasing high-value care in things such as statin prescribing, breast cancer screening, and also different types of imaging. This forces us to accept the fact that people get tired over the course of the day and decision fatigue sets in. So what are nudges? As this group is familiar, nudges are subtle changes to the design of the environment that can have an outsized impact on our behavior. Nudges are meant to remind, guide, or motivate decisions. An example might be to set the default. This is what happens if you don't make a decision to the preferred option. Another might be prompting someone to make an active choice now, rather than waiting for them to realize that they need to make this decision later on. And lastly, because there's so much information in electronic health records and patient portals, we can also think about ways to present that information in a way that is motivating, either through increased transparency, like presenting the cost of a given treatment to a physician, or through social comparisons, letting people know when they're an outlier or either above or below a meaningful benchmark of some kind. While new to healthcare, it's important to note that the concept of nudging is not new at all. It's prevalent in most other industries, and nudges are everywhere. Think about the experience of buying an airline ticket. You can pick your flight time and fill in all of your information, but you cannot finish booking your ticket until you make a decision about trip insurance. This is called active choice. By forcing you to make an active choice, many people who do not actually need trip insurance end up purchasing it because they want to avoid the potential regret of getting sick and missing their flight or any other number of things they might come up with. Second, while binging shows on Netflix, they've introduced a default where if you do not do anything, the next episode will start playing. They used to give people something like 90 seconds to make a decision about whether or not they wanted to start the next episode, but this is down to just 8 seconds. Momentum takes over and you settle in for another episode. It's important to note that neither of these things are by accident. These companies have tested these things out in certain markets and compared them to others. In A/B tests, or essentially randomized trials, they figure out which approach is most effective for their means. In most cases, we're okay with letting consumers make these decisions, buying trip insurance or watching another episode. But healthcare is much more complex and ethically charged. In healthcare, patients often need to make medical decisions with their clinician and do not have the information or agency to make and implement them on their own. Because nudges are so influential, if the healthcare environment is designed without carefully designed nudges in mind, we believe that bad outcomes are likely or even inevitable. This approach to problem solving has come up before and led to the creation of nudge units across the world. These are behavioral design teams that take a systematic approach to testing ways to use nudges to improve decisions and behavior. The first ever nudge unit, the UK Behavioral Insights Team, was embedded within the UK government, and their goal was to improve the lives of UK citizens. They found ways to get people to pay their taxes on time, increase organ donor rates, and increase charitable contributions, among a whole list of other things. Nudge units have now spread all over the world. The ones in pink on this map are run by government, those in blue are run by different countries, and green are outside of government, like the International Monetary Fund. It wasn't until 2016 that a nudge unit was launched within a health system, and that is the Penn Medicine Nudge Unit. Directed by Dr. Mitesh Patel, the mission of the Penn Medicine Nudge Unit is to leverage insights from behavioral economics and psychology to design and test approaches to steer medical decision-making toward higher value and improved patient outcomes. The founding of this group was essentially a collaboration between two existing centers at Penn Medicine. The Center for Health Incentives and Behavioral Economics, or CHIBE, run by Kevin Bolt, is a rigorous research organization meant to study ways to improve health policies. And then there was also the Center for Healthcare Innovation, run by David Ash, which is a pragmatic group started by the health system to improve the delivery of healthcare and the experience for patients at Penn Medicine. The Nudge Unit was really intended to bridge these two centers, to conduct rigorous research studies that can inform the broad development of nudges and the broader literature, but also was intended or to be paired with pragmatic implementation within the health system. Our approach here at the Nudge Unit consists of four main tiers: to advise, implement, evaluate, and disseminate. The bulk of our projects have been centered around nudging clinicians, which involves altering the design of practice environments to optimize decision-making and workflows to provide high-value and evidence-based care, and also focus on patients, nudging them in ways that alter their behavior to improve health outcomes. Since launching in 2016, we've worked on over 50 projects within and outside of Penn Medicine across more than 12 specialties. Outcomes of interest are wide-ranging and have included flu vaccination, cancer screening, statin prescribing, opioid prescribing behavior, HIV screening, glycemic control, and physical activity. And really the list goes on. We'll go through some of these examples later today. Okay, so a brief recap. So far we've done a kind of healthcare primer. We've covered nudging in healthcare and covered the Nudge Unit origin story. So next, let's get into some operational details. First, how do we come up with all of these nudges? In our experience, the four main sources for ideas come from health system leadership, internal priorities and ideas, frontline staff, and other external partners. The first pathway of obtaining ideas is directly from health system leadership. Clear goals and priorities are set by the health system, and when possible, we try to match our projects to these needs. An example of this, there was a system-wide initiative to improve flu vaccination rates. We were made aware of this priority through members of our steering committee and decided to take this issue on. Through an active choice intervention in the EHR, a group helped to increase influenza vaccination rates at 3 internal medicine practices by 7 percentage points, or a 37% relative increase. This is an area that we continue to work on, and just this year we partnered with BCSG, or Behavioral Change for Good, which is co-directed by Dr. Angela Duckworth and Dr. Katie Milton, to run a mega study related to this issue, which is currently in the field. Speaking of our steering committee, this group is made up of 8 individuals with expertise in behavioral economics, healthcare innovation, population health, and IT, and it includes executives such as the Chief Medical Informatics Officer, Chief Medical Officer, and a VP of the health system. We meet with the steering committee biannually to discuss progress on existing projects, as well as to discuss ideas for new projects. This oftentimes includes ideas on how to scale an existing project or suggestions for how to further improve an existing one. Outside of these biannual meetings, members of the steering committee also frequently reach out to us with additional ideas. Sometimes it's a priority of the health system and they think it would be a good fit for the Nudge Unit, or they know of another group working on something similar to one of our projects and want to make a connection. Second, we source ideas from within our Nudge Unit team. Situated within the School of Medicine and health system with a combination of MD and PhD researchers, our own team is exposed to ideas from many different sources. For example, Dr. Shri Adusumali, who's our Clinical Innovation Manager, is an MD by training and a cardiologist who leads our cardiology-focused portfolio. He's developed an opt-out default pathway for cardiac rehabilitation referral. He's deployed active choice interventions directed at statin prescription within the EHR and designed ways for clinicians to refer advanced heart failure patients to home care programs more easily. We also have 4 postdoc fellows within the group, including myself, and we each have different research agendas, which range from network analysis to physical rehabilitation. Given my own research background in low-value care, I'm now focused on a project related to high-risk medication prescribing. I'll also note that besides new project development, we also try to iterate on our previous successes. How can we move the needle further or expand pilots to other sites, or expand existing projects to new settings? For example, moving something from inpatient to outpatient. We also love to source ideas from our community, the clinicians and providers who will ultimately be the end users of these changes. When the Nudge Unit was first getting started, Dr. Patel would keep an ear out for projects that could be a good fit, and he even went on a kind of listening tour, meeting with individuals throughout the health system to hear what their pain points were and priorities were for improvement. In recent years, we've now formalized this process. First, we've created an office hours system in which anyone from across the health system can make an appointment to meet with our staff. Second, we have introduced an annual call for proposals, which is a kind of innovation tournament in which we ask the whole Penn medicine community, do you have an idea for a nudge? In 2018, the first year this was launched, our team received 60 submissions and 6 were ultimately deemed as finalists. Finally, while most of our partners are within Penn Medicine, we have a few partners at other health systems such as Sutter Health, or even within industry such as Deloitte. As we continue to grow and mature as a group, we'd like to continue to explore partnerships with payers, as this seems to be a ripe area for collaboration, and we're also open to collaborating with other institutions. So once you have all of these different ideas come across your desk, how do you decide which ones are a good fit and how do we prioritize them? First, of course, the question is, can the opportunity be addressed by a nudge? Is it a good fit? It's best if a nudge fits within existing workflows and does not increase cognitive load. For example, defaults are better than pop-up alerts, which are better than just simple reminders. So we could think about different use cases for each. It's also important to think about the relative strength of the different nudge methods, default versus active choice versus peer comparison, et cetera, and we'll get into this a little bit on the next slide. Next, we consider scalability. It's better if we can test something in a smaller setting, iterate and get it right, and then scale more broadly. We also like to leverage technology, things like the EHR, rather than coming up with programs that would require hiring more personnel to do manual tasks. This also greatly contributes to the potential sustainability of the nudge intervention. And lastly, we consider potential impact. Is the intervention likely to have a smaller or larger impact on behavior? Of course, larger is better, but if the opportunity addresses only one issue in a multi-step process, it may not be that effective. Also, thinking about what the intervention is trying to do. Is it trying to increase high-value care or decrease low-value care or something else altogether? Relatedly, how many patients is this intervention likely to impact? Okay, so if we've decided that a given problem is well suited for a nudge intervention, the next question is what type of nudge to use. Not all nudges are created equal. To demonstrate this, based on the Newfield Council of Bioethics Intervention Ladder, Dr. Patel created the Nudge Intervention Ladder, which can be applied to any type of clinical setting. Using cancer screening as the example here, you can see that nudges increase in effectiveness as well as paternalism as you move up the ladder. The key question is what kind of nudge best fits the problem in context. In this example, framing information in a way that motivates behavior may improve cancer screening, but defaults are likely the strongest approach to behavior change. Just make cancer screening the path of least resistance. Beyond picking a type of nudge, there are many other things we consider before pursuing a project. First, what is the issue and what is the current guideline, or what's the guideline that we're trying to nudge toward? Who sets that guideline? Is it evidence-based? and is it well accepted? Second, what does the baseline data look like? Is there a lot of variability, and is there significant room for improvement? Third, does stakeholder buy-in exist? Stakeholders are something that we spend a lot of time thinking about. If you're implementing an intervention outside of your own department, you especially want to consider the possibility of partnering with a clinician champion. Fourth is the idea of a department priority or a health system priority. In addition, we have our own internal priorities that we consider. For example, would a new project allow us to expand into a new department or a new location? Once we gather all this information, we make an informed decision about next steps, whether that's partnering up or giving feedback to the team to work on before the project can move forward. So how does all this work get done? Like most things, teamwork makes the dream work. Besides our director, Dr. Mitesh Patel, and our assistant director, Tori Hilbert, we currently have a team of 14 individuals, which is made up of postdoc fellows, data analysts, project managers, and clinical research coordinators. This is the group that makes all of these things happen. So with that, I'm going to transition into some examples and lessons learned from the nudge unit. So if you remember back to the nudge ladder, this example comes from the top of the food chain, default. First, I want to point out that we're being nudged all the time, and most of the time we don't even realize it. So this is a screenshot for a clinician who's prescribing CoReg, which is a brand name beta blocker. Like any good search engine in the EHR, if you look for CoReg, it will show you CoReg. But what this is doing inadvertently is that it's nudging you towards the brand name prescription. The brand name is listed first and the generic is at the bottom. Clinicians are often searching for these medications quickly, and they probably have a bunch of different medications to get through. They're likely to take the path of least resistance and pick the medication from the top of the list that has the right dosage. They just aren't always going to scroll all the way down to the bottom to find that generic. It turned out that this was a major issue at our health system and is a major problem across the entire country. After a series of pilot interventions or pilot studies, the health system decided to add a checkbox called Dispense as Written down here at the bottom of this window. This is a checkbox that has been on physical prescription pads for decades, but just never made its way into the EHR. The idea is that regardless of if a physician prescribes the brand name CoReg or the generic, this prescription would go to the pharmacy as a generic unless the physician checked that box. If a physician really wanted to prescribe the brand name, that's totally fine. They simply needed to check this. On this figure, we see the generic prescribing rate for the top 75 most prescribed medications before the intervention. Across medications, you can see that there's a lot of variability, but within medications, things are pretty consistent over time. In November 2014, this checkbox was rolled out to the entire health system, and essentially overnight, the generic prescribing rate shot up from 75% to 98%. Penn Medicine became a leader in generic prescribing in the region and has maintained that designation since this change. Importantly, you see this one medication that did not go to 99%, and this is Synthroid, which is a hypothyroid medication. With this drug, physicians actually need to weigh the brand or a generic option because while the active ingredient is the same, the chemicals that are in the coating of the pill are different and is actually metabolized differently by different patients. So this drug is an important case study. Here we see that clinicians can and are opting out when appropriate. In essence, they are not being tricked by this nudge intervention. Over a 2.5-year period, accounting for these 75 medications, we're ultimately talking around something like more than $32 million in savings for the health system. And kind of most incredibly, this is an intervention that took less than 1 hour to implement. This project and this kind of approach was really eye-opening for the health system. And for anyone who's paying super close attention, you'll notice that this project predates the formal launch of the nudge unit. This is work that was done in 2014. And that's because this is work that Dr. Patel completed as a fellow. In many ways, this project was the impetus for starting the nudge unit. The idea was, could this kind of work be done more systematically and this demonstration garnered buy-in for the launch of the nudge unit. Now, let's take a step down the nudge ladder and talk about active choice, getting into another example. So the goals of active choice are to prompt a decision and make it easy to say yes. Back in 2012, one practice in the health system implemented a best practice alert, or a BPA, to physicians and medical assistants in order to increase flu vaccination. In partnership with the practice, we helped to evaluate this intervention. In the first 2 years, we can see that the two practices look pretty similar, and that in the third year post-intervention, both practices increase, but the intervention practice increases by more, by approximately 6.6 percentage points, or a 38% relative increase. This could be considered a win, but the team did not stop there. In talking to physicians, our group heard about issues of alert fatigue. With this information in mind, the nudge unit made a recommendation to the health system that before scaling this type of intervention, they, 1, reduce the total number of notifications that each practice can pick, limiting them to their top 3 to 5, and that 2, this alert should be redirected to medical assistants. This alert really does not need to go directly to the physician. Instead, the medical assistant can receive the alert, template the order, and this in essence makes the flu vaccination a default for the clinician. They just need to sign the patient chart. This refined approach was rolled out to 3 practices, and using 8 comparison clinics, we found that this intervention, which actually decreased cognitive workload for the clinician, was more effective. It increased vaccination by about 9.5 percentage points. So moving along, continuing with the population health trend, like many other health systems, we struggle to prescribe guideline concordant statin therapies. At Penn Medicine, approximately 40,000 patients are eligible for a statin therapy, but only about 50% of those individuals have actually received a statin medication. We were told this topic was a key priority for the health system and ultimately decided to take this problem on, designing a 3-arm trial that tested the effect of patient dashboards and peer comparison. Remember, different levels of the nudge ladder. Our study population ultimately included 96 primary care providers from 32 eligible practice sites across Pennsylvania and New Jersey. And these 96 PCPs were responsible for 4,774 patients who met AHA criteria for a statin, however, were not receiving a statin prescription. We randomized the clinicians to these 3 different arms, either usual care, where we followed them for 2 months, or to an active dashboard, where physicians were given information on eligible patients and an active choice to prescribe, or physicians were given the dashboard with peer comparison, telling them how they did against their peers in the health system. Importantly, we tiered this peer feedback in order to avoid regression to the mean. If you were below the median, you were compared to the median. If you were above the median, you were compared to the 90th percentile. And if you were above the 90th percentile, you were recognized as a top performer, told you were doing a great job, and to keep it up. So this is what the top of the dashboard looked like. Physicians had the ability to click this button, and all eligible patients would be prescribed a starting dose of a statin therapy. I'll note that the average physician had 55 patients on this list, but some had more than 250. This is what the dashboard looked like if a physician went patient by patient. There was some important clinical information presented over on the left, things like LDL and ASCVD risk score. And then clinicians were given 3 different ways to say yes and just 1 way to say no. They could either say yes to the default statin prescription. They could stick with the same medication but request it at a different dose, or they could prescribe a different statin altogether. Then in terms of opting out, they were given an option to not prescribe. However, if they did that, they were asked to provide a justification. There are 2 big things to keep in mind here, or kind of ways in which the deck was stacked against us. 1, clinicians very well could ignore this dashboard altogether. 2, we were also making a unique ask. We were asking these clinicians to prescribe a new medication outside of the context of the actual face-to-face or telehealth visit, which is kind of a novel idea. Getting into the results, we see that in the control arm, 2.6% of patients were prescribed a new statin therapy during this 2-month period. The active choice arm doubled this, but the most effective arm was active choice with peer comparison, which was statistically different from the control and essentially tripled statin prescribing. This kind of dose-response relationship mimics the nudge ladder that we talked about earlier. And I'm also happy to report that in exciting news, Dr. Patel and the nudge unit has received a large NIH grant and approval from the health system to refine and then ultimately scale this intervention to all Penn Medicine primary care clinics. Okay, so transitioning to another example here. So far, I've really talked about interventions to reduce overuse or to think about how we get people to use effective therapies. I just briefly want to talk about an example in which the nudge unit attempted to reduce overuse, which perhaps a more challenging endeavor. This means that we're trying to get clinicians to stop providing certain services. So that omission bias that we talked about earlier today should come to mind. A type of overuse, it's been estimated that more than 30% of inpatient laboratory tests are unnecessary. In getting closer to the bottom of the nudge intervention ladder, the nudge unit helped to test the effect of displaying Medicare allowable fees for inpatient laboratory tests on clinician ordering behavior over the course of 1 year. This concept, very prevalent and also somewhat controversial in the health policy space, is known as price transparency. Taking place at 3 hospitals in Philadelphia, inpatient lab test groups were randomly assigned to either display Medicare allowable fees or not to include this information. And ultimately, 30 tests were randomized to have to have the price information, and 30 tests were randomized to not have information on cost. And here's just a screenshot when searching for these labs in the control arm. There's no data on cost here, but in the intervention arm, you can see the incremental cost for each of these tests. So moving into the results, as you can eyeball here, in adjusted analyses of the intervention group compared with the control group over time, there were no significant changes in overall test ordering behavior. I will note, however, there was an interesting finding in some additional secondary data analyses. There was a small but significant decline in the ordering of expensive tests, but this was offset by an increase in ordering of less expensive tests. For cheap tests, the intervention may have actually created some kind of moral hazard, where a physician might see that something just costs a few cents or a few dollars, so they decided to order it anyway. Considering and exploring both the intended and unintended consequences of any intervention are so important, and this particular result really highlights the importance of careful framing. As a final example, I want to mention an ongoing project that I'm hoping to lead called COVID Safe. This program is a great example of what it means to conduct embedded and rapid cycle randomized control trials. Prompted by the COVID-19 pandemic, the nudge unit was approached to help design and implement a COVID-19 screening program at the University of Pennsylvania. Happy to apply our expertise and resources to help with this cause, we've deployed a bi-weekly screening program that uses a Penn-developed saliva-based screening test. Importantly, while standing up this program, we simultaneously embedded an RCT within the program in order to assess behavioral methods to increase program enrollment. To date, more than 1,200 people are enrolled in bi-weekly screening, and the results of this trial are still pending. They're wrapping up in the next few weeks, and we look forward to getting into that data. As a final thought on lessons learned, some interventions are big winners, and others, as it turns out, are less effective. In healthcare, as well as other settings, I think the future of this kind of research lies in multifactorial experiments that carefully consider and examine the mechanisms that underlie these nudge interventions, rather than simply testing if they work. So to kind of wrap things up, I want to briefly touch on dissemination. We want nudge units to be everywhere, in all kinds of health systems across the country. Given the fragmented nature of our healthcare system, moving the needle on any of these issues on a national level will require multiple nudge units and the application of behavioral principles at all levels of the health system and policy making. With this broader mission in mind, our group has launched and started to host the Nudges in Healthcare Symposium, the goals of which are to assemble health systems interested in implementing nudges or forming nudge units, 2, to share insights on lessons learned, and 3, to network and build collaborations across health systems. Across the 2 years that we've hosted the symposium, we've had 30 domestic and international institutions attend, and we look forward to growing this number in years to come. So in summary, medical decision-making is often suboptimal. For numerous reasons, we often do too much or do too little. And whether or not we're aware of it, the design of our environment and the corresponding choice architecture influences our behavior. We need to align the design with our long-term goals. We argue that nudge units offer a systematic approach to design, test, and implement interventions that can be used to steer decisions in healthcare toward higher value and better patient outcomes. With that, I'll just make a kind of final plug for people to visit the Penn Nudge Unit website. It's incredibly well maintained. We just covered something like 5 examples today, but any projects we've ever worked on are really nicely filed and organized on the website with links to different published papers. So for people interested in learning more, I'd recommend that as a jumping off point. So with that, I think I'll pass things over to Jackie, and maybe we have some time for questions.
Great. Thank you so much, Allison, for that super interesting presentation. I encourage anyone that has questions, please send it through the Q&A box. I'll do my best to monitor. We do have one question here. How have these initiatives been received by different interest groups? So example, the frontline clinicians versus hospital administrators. And this person asks if there's been any resistance, and if so, can you share any strategies that have been effective to get buy-in across those different stakeholders and levels?
Sure, it's a great and really important question. And I think buy-in is the kind of key word there. So in terms of starting the Nudge Unit group, which again is directed by Dr. Mitesh Patel, it all happened really organically through the Center for Healthcare Innovation and CHIBE, the Center for Health Incentives and Behavioral Economics. The kind of Penn community has become pretty accustomed to this way of doing research and this kind of approach to quality improvement in healthcare. So kind of from the big picture buy-in perspective, people are really supportive of the type of work that we're doing and this kind of approach to trying to improve quality and improve decision-making within the health system. I think something that our group is really careful about and thinks a lot about, again, when sourcing ideas for projects, is getting input from leadership and from frontline staff from the very beginning. We don't want any surprises, and we don't want to be surprising anyone else. Another important piece, we are quantitatively evaluating everything we do, but we often have a qualitative piece to the puzzle too. So before we're implementing, we're doing some contextual inquiry. We're asking physicians about their experiences to get both input, but also buy-in to implementing this kind of intervention. And then after something is rolled out, we're getting feedback on the back end as well. And oftentimes, you know, we launch a project in its first iteration, but we kind of do those as pilots and we try and iterate whenever possible. So I can say within COVID space, which is a little bit more patient focused, we're iterating what feels like daily. So right now things are pretty regimented where people are scheduled to go into the lab to complete their test. But we've heard that with flexible work schedules and people working remotely, it's just hard to predict. So we're now kind of rejiggering the whole system where instead of the lab expecting people on a given day, we're flipping that whole system so people can kind of go whenever it is that they're on campus. So we constantly have our ear to the ground to be incorporating feedback as we go along.
Great, thank you. So we have another question about how you might be collaborating with other health centers with regards to the interventions that you know work well. So I guess scaling efforts, and how are you bringing those insights to other health systems?
Yeah, that's a great question. So I think that speaks to dissemination. Of course, you know, in research and in academia, we're often focused on peer-reviewed publications, and that is a major part of what we do. We're pre-registering all of our trials and publishing them and trying to disseminate the work rigorously in that way. But we know that those sorts of papers or those sorts of results don't always make their way to decision makers and key decision makers and stakeholders at different health systems, even potentially, you know, embedded within government. Center for Medicare and Medicaid Innovation are making huge policy decisions all the time, some of which could incorporate some of these features. So we also try and disseminate our work in more user-friendly ways. That could be reports, Twitter. I think our website, as I mentioned before, is a really great resource. But then I do think that that symposium that our team has been running is a big key to our attempt to kind of grow this approach and spread the word. So in terms of partnerships, as I alluded to before, we have some collaborators out in the Pacific Northwest near Sutter Health. So with them, an RCT was launched to try and reduce rates of opioid prescribing. We're certainly trying to kind of grow this network as we go, and based on lessons that we have learned, try and make it as easy as possible for other people to get started in this space.
Excellent, thank you. We could do a couple more questions before our time is up. I'm curious, so right now the team is centralized. How do you think about the future of the team decentralizing this behavioral lens and really empowering physicians to do some of this work on their own as well?
Yeah, that's a great question and something our team has been thinking a lot about. In 2016, 4 years ago when this group launched, it was 2 people, and now we're up to 15 or so and have been hovering around that number. But even with a really great team and really great infrastructure, there are only so many projects that our group can take on and really implement, launch, do all of the pieces ourselves. So in recent years, we have tried to shift to a little bit more of a consulting model, where we try and make sure that the Penn Medicine community knows who we are and the kind of work we do and what we can help with. But then we're kind of trying to guide certain people through the process on their own. So consulting with them about what the problem is that they're trying to solve, consulting with them about what nudge might be the best fit, and making connections that they need with the IS team to potentially implement things in the EHR and those sorts of things. And again, also helping them with the evaluation piece, but taking a little bit more of a back seat, and kind of giving more of that ownership over to those frontline staff members who are coming up with these ideas and trying to implement them. So I think that is beneficial in 2 ways. One, we're able to, train people in these methods along the way and kind of spread these methods as we go. And then 2, by going to that kind of model, we can just be working on more projects at one time than if our team were to be taking on all of those responsibilities.
Great. And I see some questions in the chat. They're specifically on example projects. There's one for community-based cardiac rehab programs, especially in COVID, another on examples to nudge nurses and patients. Perhaps though, you mentioned that all of these projects are on the website, so people that do want to see all of the work the group has done, I would nudge you to go to their website and check that out. Let's just check. Okay, one more question just came in. What have been the objectives to, or objections to opening nudge units in other systems that you know about? So perhaps maybe if you know of other health systems that have tried and challenges that they might be experiencing.
Sure. I'm trying to think if there have been objections. I think the kind of biggest barrier to entry are just to kind of get the resources that are needed to start these groups. At the different health systems where we've seen this kind of concept spread, I think there's typically, one researcher or one physician or a couple of people who really buy into this approach and are interested in scaling this approach. And kind of typically they start this work in their own personal line of research. And then once they have some kind of win that they're then able to present to those decision makers, they're able to get more buy-in to kind of expand this approach. But certainly our kind of big agenda item is that we should be doing this systematically. So continuing to inform diverse stakeholders and decision makers about this approach, I think is how we can kind of scale this more widely. In terms of objections, I think a big thing that comes up, not necessarily to standing up these nudge units, but this type of research is randomizing people to these different arms, and the extent to which people are aware of the fact that they're being randomized, or if they're being randomized without their explicit consent. Sometimes if you're randomizing people, you'd be unable to study the questions that we're interested in. So a lot of our work ends up using waivers of consent, either for physicians or for the patients themselves. So where this research fits in as it relates to the IRB and as it relates to quality improvement more generally, I think ends up being a big question mark for a lot of people and sometimes takes some convincing. But our kind of thinking is that, again, nudges are everywhere and we're frequently unaware of them. Things are changing in the electronic health record all the time. So to the extent that we're focused on the standard of care and just improving the standard of care, we think it's reasonable and really important to be testing these things rather than just doing them without any sort of evaluation.
Thank you. With that, I think I'm going to pass it to Maya to wrap up for us.
Yes, thank you so much, Jackie, and thank you, Allison. And for everyone, thank you so much for joining us today. When the recording becomes available, it will be posted in our Twitter page as the other recordings from previous webinars. So thank you again so much, and we look forward to seeing you again for our next webinar. Take care, everyone.
Thanks.
Thank you.